Hello, to come back to the accessory nerve, let us go through the course once again. The accessory nerve has a cranial part, it has a spinal part. The cranial part begins its journey from the nucleus ambiguous and dorsal nucleus of the vagus, deep inside the medulla oblongata. The spinal part of the accessory nerve begins its journey from the upper 5 cervical segments of the spinal cord from the lateral side of the anterior horn. The spinal part of the accessory arises alongside the spinal cord between the ventral and dorsal roots. It enters the foramen magnum behind what we call the ligamentum denticulatum, which is a process of the pyometer, and once it is inside the foramen magnum, it passes laterally towards the jugular foramen. On the other hand, the cranial part of the accessory exits the medulla oblongata on its ventral surface in a groove between the olive and the inferior cerebellar peduncle in line with the glossopharyngeal and vagus nerves. So 9th, 10th and 11th cranial nerve exit the medulla oblongata in a vertical series, and after this exit from the brain, the cranial and the spinal parts of the accessory come close together, pass laterally towards the jugular foramen, and in the jugular foramen they are passing from inside the cranium, from inside the skull to outside the skull. And the 9th, 10th and 11th cranial nerves, although they are passing together, often they are separated by small meningeal or pial partitions or dural partitions. And when they are coming out of the cranium below the jugular foramen, the cranial part of the accessory blends with the vagus just above the inferior ganglion, and the spinal part of the accessory separates out and enters the upper portion of the anterior triangle. The cranial part of the accessory is distributed along with the vagus, particularly along the pharyngeal branch of vagus, recurrent laryngeal branch of the vagus, and along with the cardiac branches of the vagus. The spinal part of the accessory passes deep to the internal jugular vein. Occasionally it may pass superficial to the internal jugular vein or even through the internal jugular vein. Behind the internal jugular vein, it passes superficial to the transverse process of the atlas, and somewhere here it is crossed by the occipital artery. In its oblique course downward and backward, it is accompanied by the lower sternomastoid branch of the occipital artery. And then it passes deep to the styloid process and the stylohyoid and posterior belly of the digastric. And it pierces the sternocleidomastoid muscle at its junction of the upper 1/3 and lower 2/3 of the anterior border. Within the sternocleidomastoid muscle, it supplies the sternocleidomastoid muscle, and in addition it is accompanied by fibers of C2 and C3, which are probably proprioceptive in function. It comes out of the posterior border of the sternocleidomastoid roughly in the middle, and here it is hooked by the lesser occipital nerve. Now the spinal part of the accessory is in the posterior triangle. In the posterior triangle, the nerve lies over the levator scapulae muscle. Not only that, it lies superficial to the floor formed by the prevertebral fascia, which is a part of the deep cervical fascia. That means the accessory, the spinal accessory nerve, is a true content of the posterior triangle. In its course in the posterior triangle, it is accompanied by fibers of C3 and C4 nerves, which are partly proprioceptive and partly motor to the trapezius. Anyway, the spinal part of the accessory enters the trapezius through its anterior border, roughly 5 centimeters above the clavicle, and along with the fibers of C3 and C4, it forms a subtrapezoid plexus. In its course in the posterior triangle, the spinal part of the accessory is also related to a number of superficial and deep cervical lymph nodes. These are the things you must keep in mind. Now if we go to this diagram, here you can see the result of damage of the spinal part of the accessory in the posterior triangle. Damage to the spinal part of the accessory causes paralysis, weakness, and shrinkage of the sternocleidomastoid muscle. And the postural deformity that you have is that the paralyzed sternocleidomastoid is unable to push the face and the head to the opposite side, and therefore the healthy sternocleidomastoid will deviate the head towards the paralyzed side. So after this deviation, there is going to be further degeneration, shrinking, and cord-like hardening of the sternocleidomastoid. This paralytic spasm-like hardness of the sternocleidomastoid along with a deviation of the head towards the paralyzed side is also called torticollis. Apart from that, due to paralysis of the trapezius, we wouldn't say paralysis because there is an additional supply by the C3-C4 muscle. Mere cutting of the or damage to the spinal accessory is not sufficient for total paralysis of the trapezius. However, there is considerable weakening of the trapezius with drooping of the shoulder. Now, this condition can commonly occur when surgical incisions are made in the posterior triangle to drain abscesses within the lymph nodes over here. Either pyogenic abscesses or biopsies for tubercular abscesses can injure the spinal accessory and cause weakening of both the sternocleidomastoid and the trapezius. That's all for this video. Thank you.